definitely.
Yeah, another half an hour maybe. Okay, so this topic is about inflammatory bowel disease. It's again a tedious topic, like viral hepatitis, because it encompasses a group of heterogeneous diseases, namely ulcerative colitis, Crohn's disease, and colitis unspecified or indeterminate colitis. Right. Then, in educational objectives, just to the spectrum of inflammatory bowel disease, the epidemiology, the pathophysiology of IBD, how they manifest both ulcerative colitis and Crohn's disease. What are the distinguishing features, clinical features between ulcerative and Crohn's disease? The diagnostic approach to IBD in general, complications, and finally the treatment. Okay. Now, it is a chronic relapsing. This is very important, and that's why I underscored this term, because it comes and goes. It has ups and downs, and for sometimes reasons that we don't know. Ulcerative colitis, it's the ulceration of the mucosa in a diffuse pattern, while Crohn's disease, it's more deeper ulcerations and transmural, reaching the serosa, and that explains probably the complications of Crohn's disease, which could be stricture, obstruction, and abscess fistulas. The epidemiology, I'm not gonna, give much importance to this, but it is rapidly increasing worldwide. When I was in medical college, it used to be a disease of Northern Europeans and Jewish and stuff, but it's not true. IBD is creeping in the Southern Hemisphere, and now it's not as common in Jordan as in Sweden. I'm not saying that, but it's pretty common. It's not uncommon. It has two peaks, well, the so-called bimodal distribution. Most of the time, the patients that we see, their age are anywhere between 15 to 25 years, but we see also patients, less commonly, in the age range between 45 to 55, 60. Okay, so don't rule out IBD in an older person just because he is old. As you probably know, IBD is most common in the industrialized countries. We mentioned that already. The etiopathogenesis is quite complex. It's probably it's multifactorial. So it's not only an infection or luminal agents or other environmental triggers. It's also the genetic susceptibility. So you need to be born with the gene to develop IBD, especially in Crohn's disease. And again, here, as you can see, there's all this talk about infections, mucosal integrity problems, dysbiosis, dysimmunity, quite complex. So at the end of the day, in order to develop IBD, you need your pro-inflammatory factors to prevail on your anti-inflammatory factors. Genetic susceptibility has been studied in identical twins, and they found that in Crohn's disease, only 50% of the time, the monozygotic twins, they develop Crohn's disease. So the other 50% they don't, meaning that you need not only genetic susceptibility, but also environmental factors. In ulcerative colitis, the genetic predisposition is less important. So what are the clinical manifestations of ulcerative colitis? Well, that depends on the two things, the extent, location of the disease, and the severity. If it's only in the rectum, it's proctitis, and all you get is tenesmus, mucus, and little blood. If it's beyond the rectum, you can have bloody diarrhea. And if it's severe with pancreatitis, you can have even toxic symptoms, such as fever, anorexia, etc., etc. Distribution, the most common of ulcerative colitis distribution is left-sided colitis, rectum, sigmoid, and descending colon, followed by, in 1/3 of the patients, by pancolitis, involvement of the whole colon, and less commonly, something like called the proctitis. So how we rate the severity of ulcerative colitis. There are clinical and laboratory. There are several, scoring test systems, but this is the most commonly used. The number of bowel movements, blood in the stool, yes or no. If yes, small, moderate, or severe. Fever, yes or no. Tachycardia, and some laboratory tests. The degree of anemia, the ESR, and the endoscopic appearance. You need not to memorize all these numbers, but know that your patients are classified in mild, moderate, or severe based on these 7 criteria. This is the perfectly normal colon with the reticular vessels nice and visible, nice and shiny here, okay? And look at this here. So I don't think you need an endoscopist to say this is abnormal. Look here and here. This is severe ulcerative colitis with spontaneous oozing. The clinical manifestations of Crohn's disease, okay, well, similar to ulcerative colitis, except for there is more of a watery diarrhea, even though in Crohn's colitis, patients can have bloody diarrhea. But the most important thing that Crohn's disease often present with abdominal pain and weight loss. And these are the most common symptoms, probably. This slide talks about the distinguishing features. We said at the beginning of this lecture, I said that because of the transmural nature of the disease, it can cause strictures and it can go on to develop fistulas, etc., etc. Distribution, well, most commonly ileocolic, terminal ileum and right colon, followed by small bowel and then the colon alone. And in a small proportion of patients, 1-2%, it can involve even the upper GI tract. Remember that while ulcerative colitis is a disease exclusive of the colon, Crohn's disease can hit the individual from lips to anus. So this here is Crohn's, this here is Crohn's. See the aphthoid lesion here. This is ulcerative colitis. So skip lesions, segmental lesions in Crohn's, diffuse disease in ulcerative colitis. This is a surgical specimen from a patient with severe Crohn's disease. Note the serpiginous deep ulcerations here. So similar to ulcerative colitis, there is also a severity index for Crohn's. It's not the only one, but this is the most commonly used. And it incorporates 8 variables: the number of soft stools, abdominal pain, yes or no, presence of extraintestinal manifestations, complications such as abscess or fistula, abdominal mass, the need for antidiarrheal medications, and hematocrit. Okay, all of these can really be, extra manifestations of IBD. Basically, every and each organ system can be affected, from the eyes to the skin to the bones to the liver. So remember that Crohn's and ulcerative, both of them, they have a very florid group of extraintestinal manifestations. They can be sometimes the presenting complaint. Like in Crohn's disease, many people, they came in with low back pain, okay, or with recurrent iritis. Or in ulcerative colitis, they get pulmonary, Erythema Nodosum, okay, which is here, raised, purplish, slightly raised, painful nodules, or something so ugly such as Pyoderma Gangrenosum, non-healing ulceration, deep ulceration of the skin, or sausage digits, severe arthritis, or inflammatory arthritis, the so-called enteropathic arthritis, Sacroiliitis, which is, if severe enough and long-standing, can lead to this, Ankylosing Spondylitis, with this kind of deformity, iritis, uveitis, scleritis, okay, so eye disease, or PSC, primary sclerosing cholangitis, Stricture dilatation, and this is an ERCP picture. Right, so what are the distinguishing features between ulcerative colitis and Crohn's disease? Okay, in yellow, those things that are more common in ulcerative, tenesmus and rectal bleeding. For everything else like fever, abdominal pain, mass, tenderness, or weight loss are more common in Crohn's disease. Of course, the other complications like obstruction, fistulas, obstruction of the colon, the small bowel, they're more common in a Crohn's disease. Recurrence after surgery, of course, is much higher in Crohn's disease. Okay. Endoscopically, well, as I said, the hallmark of the main thing is that Crohn's disease is skip lesions and segmental, as opposed to diffuse, lesions in the ulcerative colitis patient. Another thing, you get cobblestoning, okay, in Crohn's disease. You get rectal sparing in Crohn's disease. Now we have something new called indeterminate colitis, which is something in between the ulcerative colitis with diffuse kind of involvement and the Crohn's with these deep ulcerations. And sometimes not even the biopsy can differentiate between the two. But most of the time, patients with indeterminate colitis, they turn out to have Crohn's disease. What is the diagnostic approach? Well, history is the most important thing. Take a good history from the patient, examine the patient, get a battery of tests, and then you can proceed to radiology, whether CT or endoscopy. Then sometimes serological testing and genetic testing, but this is done in research centers only. So the blood tests in Crohn's and ulcerative, they are similar. There is anemia in general. There can be hypokalemia when the diarrhea is severe. CRP is most elevated in Crohn's. ESR is most elevated in ulcerative colitis. Anti-ASCA, anti-Saccharomyces cerevisiae antibody is more likely to be positive in Crohn's, while the p-ANCA is more likely to be positive in ulcerative colitis. But don't forget to order stool analysis, not to diagnose Crohn's or ulcerative, but to rule out that there is infectious colitis. Remember this. Because if you get a patient from the Jordan Valley, for example, this guy is more likely to have amoebic colitis than ulcerative colitis. So remember, the stool analysis is a cheap and very diagnostic test. We have endoscopy. Endoscopy is important for several reasons. We get initial diagnosis. We can get a tissue diagnosis, so the histopathology, assess the severity, the extent. We follow up during treatment. We assess the disease exacerbation, surveillance for risk of cancer, and to treat even. Sometimes certain strictures in Crohn's disease can be treated by balloon dilatation and endoscopy. Severe disease of Crohn's, ulcerative, the left, Crohn's on the right. What are the endoscopic features? I think I mentioned already there are skip, segmental, rectal sparing, deep ulcers, etc., etc. Sometimes pseudopolyps, which are rare. Cobblestoning is more common. Pseudopolyps are more common in ulcerative colitis. This is the cobblestoning اللي هي زي الشوارع المدن القديمة هاي تلاقيها مزفتة أو مرصوفة فيها. All right. Endoscopic features of ulcerative colitis can go all the way from little mild blurring of the vascular pattern to diffuse ulcerations with pseudopolyps and friability and even spontaneous oozing. This is a pseudopolyp, okay? This is typical ulcerative colitis, okay? Epidemiology has certain importance because we often order CT, especially patients with Crohn's disease, also to rule out obstruction or abscess, fistula. More advanced imaging techniques are available. Magnetic resonance, it's useful because it can assess also for the activity of the disease, not only for the gross pathological findings. And then we have the so-called wireless capsule endoscopy, which is used to diagnose involvement in Crohn's of the small bowel, because again, at upper endoscopy and lower endoscopy, we see from above and below, but there's still 6-7 meters of small bowel that we can get in. So wireless capsule endoscopy can do the job. These are normal pictures, and these are pictures of patient with small bowel Crohn's disease. Again, these are chronic diseases, and obviously they're gonna have complications. GI bleeding, toxic megacolon, perforation, thromboembolism, fistulas, abscess, strictures, malabsorption, cancer, failure to thrive. All of these can be complications of IBD. This is an example of a stricture in the colon, as you can see here and here. I went in all the way, insert over guide wire, a balloon, inflated, and we got this result. So obviating the surgery for this patient. So therapy, okay, last but not least, well, what is the goal of treating patients with IBD? Well, I think first and foremost, patients need you to rid them of their symptoms. So induction of remission and maintaining of remission is the primary goal. Restoring and maintaining good, proper nutrition and improving quality of life, all in all, prevent complications and to time the surgery for these patients, if any. What do we use for ulcerative colitis? Induction of therapy? Well, aminosalicylic acid, like mesalamine, corticosteroids, cyclosporin, and the biologics like infliximab or adalimumab. For Crohn's disease, same thing, okay, aminosalicylates, corticosteroids, and anti-TNF, okay, and antibiotics as well. Maintenance, just remember that we don't use steroids for maintenance. We can use anti-TNF, aminosalicylic acid, methotrexate, 6-MP, 6-mercaptopurine, azathioprine, but not corticosteroids. Corticosteroids use must be limited to 2-3 month stops. So we discussed about the possibility of surgery. Well, surgery, if timed properly, can be life-saving and organ-saving. And that needs a multidisciplinary approach between the radiologist, the endoscopist, and the surgeon. What are the indications for surgery? The most important one is intractability, failure to respond to medical therapy. Assuming that you have ruled out that it's not IBD, but it's not infectious colitis, because remember, cytomegalovirus can resemble, and even TB, tuberculosis, resemble IBD. So again, intestinal obstruction, cancer, perianal disease, all of these can be indications for surgery. In summary, the goal is to relieve symptoms, prevent relapse, improve nutrition, control, keep the inflammation under control, and prevent complications. And the treatment depends on the type, whether it's Crohn's or ulcerative, the distribution, it's like in the rectum or pancolitis, okay, and the disease severity, of course, mild, moderate, or severe. This concludes the lecture, and I'll be happy to take any questions, if any. أسئلة questions.
دكتور يعطيك العافية.
يلا إن شاء الله تكونوا استفدتوا. هلا هي بتكون أنتوا uploaded عندكم، يعني بتقدروا تنزلوها ولا لا؟
دكتور بدي أسألك سؤال.
اتفضل طبعا.
ليش بنعطي antibiotics لكرونز؟
That's a great question. When I talked about the pathophysiology, pathogenesis of Crohn's, one of the possibilities that the Crohn's is a dysbiosis, an imbalance in the intestinal flora. So it's believed that some bacteria, they can prevail and cause the problem. And that's why in patients, especially with mild Crohn's, we give metronidazole and ciprofloxacin. So the idea is just to restore a more normal flora. But that's a very good question and has been debated for years or decades. Other questions?
شكرا دكتور.
عفوا يعطيكم العافية. أهلين.